sort of a critical mass forming, and I know everybody's got to get their day started and get onto the OR. So welcome everybody. This is our fifth installment of the West Coast Fellows Conference. We had a brief delay over the summer, but we're getting back going now and hoping to probably move towards a monthly conference in the future. So today we're very fortunate to have Dr. Anand with us, who is going to discuss staging for circumferential MIS correction of severe adult deformity, what he's learned and what he's doing now. So very excited. And I was hoping that Greg, who knows Neel very well, could just say a few words about why we're so lucky to have him with us.
Absolutely. Well, Neel is not only a friend, but a mentor of mine who's been around for years in almost a singular mission to change how we think about deformity. He, from a very early age, decided that he wanted to pursue this, and he did it the right way. And what I love about Neel is that in an environment that really was not data-driven, an environment that really, was more anecdotal reporting, Neel decided to start collecting all his own data. And what he's done in private practice on his own over the course of the last, 15, 20 years is nothing short of remarkable for those of us that like to do academic work. And for those of you going into private practice and want to know if I can still do research, so this is the guy that will show you exactly how to do it. He's, like I said, he's not only honest, straightforward. He's turned into a really good friend, and certainly love the idea that we get to travel a little bit more again, because I get to hang out with Neel a bit more and drink some really fun stuff together. So, anyways, Neel, I applaud you for being here. Thank you for being part of this conference. We're so glad to have you, and we look forward to hearing about MIS deformity surgery. Thanks, bud.
Awesome. So Dr. Anand, I'm going to stop sharing my screen and turn it over to you.
Sure. Thank you, Greg. That was extremely kind of you. Not sure if I deserve all those accolades, but thank you so much. Yes, it's been quite a journey. And I thought what I'll focus today is on staging and really what it truly has taught me, and where are we now, and when do I stage? Because I think it's sort of an issue that people bring up. These are my disclosures. Some are relevant. I do have patents and royalties on some of the products you might see. Staging is something that we've done from day one, and I'll talk to you why and where and what happened and how it really has formulated a lot of the things we've come to today. And as many of you know, we have a stage protocol for circumferential MIS correction of spinal deformity without osteotomies. I want to make this clear now. That I think that's been our mission, as Greg was saying. How can we develop this, right? So anyway, to go through that, we progressively published over the years longitudinal data on our same patient cohort over the years, giving hopefully good long-term results. And essentially the staging is the laterals and the A-lifts are done on day one. Patients walk right after that. They decompressed or not indirectly. We can reassess alignment. And then on the second stage, what's important is, and you'll see as I show you, it's not just percutaneous screws and rods. There's a whole element of reduction, translation, derotation that needs to be done depending on the case. And you'll see again how that plays out. So how did it start? Why? What did we learn? When do I stage today? And why do I still stage? I'll talk to you about that, and hopefully the younger surgeons can see that. I think a lot needs to be understood. This started in 2003 and 2004 for me. Maybe many of you fellows were not even born, probably. 1 to 2 fellows at that stage, 1 to 2 levels with TLIF for me, and still is my favorite operation, to be honest. So when this came out, it was 1 and 2 levels, and the lateral approach came in. And I didn't see much utility in that, as I was comfortable with TLIF. I'm just talking on myself now. And I used it more for 3 or more levels, which started making sense with spinal deformity. And that's how we started. And there's nobody there sort of really showing what to do. And clearly, if I'm doing 3 or more levels, I wasn't starting to do them all in one day and spend 8 hours in the OR and so on and so forth. I said, okay, let's stage it, be safe, do that. But more importantly, I was a complete non-believer in the indirect decompression, as I'm sure many still are. So I didn't believe that. I said, okay, if we stage it, at least we know if we are getting indirect decompression or not. And truly, that's how it started. There's nothing more to it than that. We had a Monday, Thursday OR And that's how we started doing it. And we soon came to know, obviously, you get excellent sort of segmental coronal correction and all that stuff. But I think what became very apparent was you were truly getting facet release. And you were able to move that facet as long as it was open. As you can see between the right and the left side, you'll see that facet realigned up there. And we started seeing indirect decompression in patients, years pre-op and post-op. And I'm sure today it's become quite common. We all know about it, right? But at that stage, again, don't forget, we knew nothing. There was no data. We did not know it. And I had to sort of prove to myself, and hopefully, as we go along others. So here's the pre-op MRIs, and you can see post-op. But another thing the astute among you noticed was, even though we did MRIs before, we started realizing there wasn't a massive difference in the MRI between the pre and post-op. And still patients are doing exceedingly well with no leg pain and the radiculopathy gone. And that taught us sort of more or less, maybe it's stability is far more important than actually foraminal volume, though we get stuck on foraminal volume and central volume. You'll see some change, but not a great extent sometimes, yet patients are absolutely fine. So it may be stability that's giving that, and that's just something I want to throw out to you guys as you watch these things. So that's one aspect of it. But then we obviously went on to doing true scoliosis. This was probably one of the first real circumferential-MIS deformity cases, and always showed where I still follow up with her. She's almost for 13 years now. And I look at 3 levels then, and at that time I was doing axial lifts. Please don't ever do it for deformity. I've openly said, do not do it. In this particular case, it worked. This is how it was going. But then we quickly realized something else, right? Look at that coronal correction after stage 1. That's not corrected. We actually were getting more posteriorly, and this was way back when we were seeing these patients. But more importantly, sagittally, we're getting it right away. And I will talk about this later. We just presented another paper recently. But if we look at the difference between coronal and sagittal correction, that's her 11 years, and she's doing really well. But then when you came to idiopathic scoliosis, this became even more apparent. And these are all patients who still follow up with me. Again, look at the coronal correction post-laterals. I'd say there's zero. There's barely any coronal correction, barely any translation. And quickly became apparent now we had to develop instrumentation and tools that we could derotate, translate, reduce, and correct coronal deformity minimally invasively without an osteotomy. So that led to the development of a number of changes today that's become commonplace in how we do these things. But still, I think a lot is not talked about it, how posteriorly you reduce these MIS. And then you can see this patient, I'll talk about it later again. We did CT scans routinely to show it. We used to do them with multiple small incisions. Today, I just do them with a single incision. Here's another patient, again, changed the paradigm. Only showing these patients, Sao Paulo, Brazil, married to a Texan billionaire, came here, wanted surgery, was told she could never have it. Here are her x-rays, massive thoracolumbar curve, MRI showing a very good 5-1 for the young surgeons. I want you to note that. Staged her, got up, walked next day with absolutely no leg pain. I'm just saying these are patients that formulated my ideas. Same thing again. Her coronal thoracolumbar curve never corrected after stage 1. Stage 2 is what brings that AVT around, pulls it around, corrects it. She is 10 years out and 5-1 is completely preserved. So I just want you guys to think about that. When you have a good disc at 5-1, you don't have to rush doing it. And I can show you many of these, but they're very selective about it. Please don't say, Dr. Anand does not do 5-1. That's not true at all. I do 5-1 all the time, but I think you got to be selective in that. Next was rod contouring. Staging taught us this. Here's another patient, pre-op, and here's post-staging, stage 1. She corrected her PI and lumbar lordosis pretty well. Then we go on to put the rod. Look how flat that rod is. Pushed her back into kyphosis and a flat back. And quickly, rod contouring is equally important. You push them right back. And it became obvious we got to develop, again, instrumentation that will accommodate a very well-curved rod to allow this to happen. And you can see, you put a flat rod in, you're going to run into trouble. So contouring, rod passage, reduction, translation, derotation, all become extremely important aspects. And we would never have known this if we had not staged it and watched these patients between the 2 stages. So we realized we had to do that, really hyperbend the rod, and learn these techniques of translation and derotation to get to the point of correcting these patients without an osteotomy. Yes, it's biased, but a number of patients I saw, like I said, were pretty big deformities, and these are the ones we are applying lateral and these techniques to, and not to 1 and 2 levels. So I do want to keep clarifying that. But till today, that's still it for me. And so now we started getting these lordosis. We're able to get the curves we wanted by the ability to pass these rods, correct and translate, which today is commonplace. But don't forget, this was 2010 and 2011 when we were just doing all these. So where are we today? Today, literally every single patient is able to do MIS without an osteotomy, as long as there's an open disc that we can tackle in our protocol. And all these patients have been treated circumferentially MIS and all staged, right? We're able to do the first stage, all single stage lateral. Because of 5-1, we were able to do an A-lift in the lateral position. So at least that stopped us turning supine in the lateral position, we're able to get all the lumbar levels. But again, if you look at the staging now, again, what it did, here's a pre-op x-ray. Here's the first stage x-ray. And right away, you see the sagittal alignment significantly corrected just by doing single stage laterals. And all we got to do is fine tune that and correct it with the posterior to do that. If we did all this in one stage, one, it would have taken a longer time. Two, we would not understand this, understand the mechanism of correction, how to go about it, how to bring this fine tuning and get it to that perfect alignment that patient needs. This taught us a lot, where to go. How much do I bend the rod? Where there's another patient. They look all the same. That's actually another patient, believe it or not. That's different. That's another patient. And again, same thing pre-op. You look at stage 1, the sagittal alignment's completely corrected. And I'm going to point out another point very soon in that we don't have to go T2 to pelvis. If I had seen this pre-op 20 years ago, I probably would have done a T2 to pelvis. And you're going to see this consistently again, where we're getting this. There's another patient, massive, but a degenerative curve. Look how pretty much she corrected quite a bit by just lining her up. This is not idiopathic, this is degenerative. And you're able to line that up post stage 2. Again, the fine tuning, the correction. Look at that sagittal alignment got from the first stage. I don't need to do a lot posteriorly other than just lock it in, give it a little bit more, and get to where I need to get to correct this. Again, with no osteotomies. And when you see an intervening x-ray like this, why would we do an osteotomy? If we did not stage, in our head, we're thinking, oh my God, I got to do an osteotomy, multiple PCOs, to get this corrected. So these are thoughts I think I'd like to sort of bring to you and see what staging did for us. Here's another patient, 65-year-old professor UCLA. Again, you can see this just coming right back, first stage, followed by second stage, and it gets monotonously consistent as we follow the protocol and go along with this. Here's this coronal view, pre-op, post first stage, second stage. So we just presented this. What are we getting from the first stage and what are we getting from the second stage? I sort of already alluded to you a little bit. This was presented at the SMSRI just recently, 122 patients, all big deformities. We had obviously good improvement from pre-op to post stage 2. What's important in between what happens, and this is interesting, the lateral gave us about half the correction of the carb angle, whereas the posterior percutaneous reduction and instrumentation gave us about 56%. But look at the AVT. This is the coronal rotation and translation of the scoliosis from the central sacral vertical line. Lateral gave only 22%. It's the posterior instrumentation that gave greater than 75% of that correction. And look at lumbar lordosis, 95% was obtained from the laterals, from the first stage. So this whole idea that laterals did not give us sagittal alignment is something that we've never had a problem with. And I actually do not understand that. And there's always talk about it. Lateral has given us the best sagittal alignment, and the posterior percutaneous reduction fine-tunes the coronal correction. The SVA, again, same thing. We were seeing more, obviously, laterals, PILL mismatch, again, most of it corrected by doing stage 1 laterals. The posterior actually corrects the coronal correction. And so it also became obvious that when you look at the residual thoracic curve, what's happening? Here are double curves, massive double curves. And you see this unbelievable unwinding of the thoracic spine. Here's our post first stage, not much changed. This is equally important. You see something like this. Now you think you need 100 osteotomies. and you need correction. This is post first stage. But then if you have the right tools, you can unwind and roll that spine over, and that coronal curve, the thoracic spine has gone to 30 degrees from a 70-degree curve, and patients don't hurt in the thoracic spine. This may be the biggest contribution of MIS surgery, where we can reduce these patients to a T10 to pelvis construct or a T12 to pelvis construct, and that's down to 37, completely balanced, asymptomatic. These patients only care about coronal and sagittal balance. It's not about getting to zero, and they don't hurt thoracic spine. So that's another. He's 1 year out now and doing pretty well. Here's another patient, private equity manager. I purposely left the dates out there. That's 8 years out. July 13th is when we did him. But this particular patient collapsed down there, younger patient. Again, same thing. First stage, followed by second, leaving the thoracic curve alone. Selective lumbar fusions for these double curves. And hopefully you'll publish that data soon with some of the early young studs we have today at Cedars-Sinai, including Corey Walker, I think many of you know. And I think he's going to work on that soon. Here's another 65-year-old tech CEO. Same thing. Again, you're seeing this across the board. But here's an interesting one. Here's the post-stage 1. She did not have enough lordosis. I was able to give her more by going in, correcting it during the posterior stage. Again, staging help. Here's another one, physician from Louisiana. And you can keep following this. This is thoracolumbar kyphosis, something with open surgery we routinely did osteotomies for. Don't do the first stage, see the realignment, and get the correction you need without a single osteotomy. So staging helped us with that. Staging helped me get to where I need to go and do what we need to do. Here's another actor, and he can just keep going on and on. Massive kyphosis all the way top to bottom. He barely has lordosis but at 5'1", but he created now a harmonic curve to give him the correction he needs. There's more physiological, a similar fashion, kyphosis going all the way on his heels, top to bottom except 5'1". And again, he gave that harmonious physiological lordosis and correction that he can fine tune with staging. And I'm leaving you these two. This is 10 years out, done in 2010. Selective lumbar fusion, left the curve above alone. She's doing really, really well. But I point to your curve here. We would do much better today with that sagittal curve. But for her, that was okay. And we got away with that. Here's another patient, 2008. These are patients that taught me a lot. Left the rod long, thinking I'm going to need to do the thoracic at some stage. This is where we started off and realized patients like this continue to do well. The thoracic spine does not hurt in the adult. If I had not staged, I would never, ever have known this and still doing T2 to pelvis to this day. We've not done a T2 to pelvis in 5 years today. What the staging protocol has taught us is after first stage, if the thoracic spine, only if it's greater than 60 degrees of kyphosis, only then do I do the thoracic spine. Last but not the least talked about operative duration is a single indicator of complications. This is single level lumbar fusion, greater than 5 years, risk of reoperation. The odds ratio was 2.17, surgical site 9 times, septic shock 4 times, wound adhesions 10 times. This is single level lumbar fusion. We're doing 7, 10, and 16 level fusions here. So I'd like you to extrapolate that. And then from your own group, greater than 5 hours, there's a lot of contamination. I didn't say it. I see all the big names there. Dr. Akbarani, I know, is on with phenomenal respect for, and I've learned so much from him over the years. And I think we got to look at time also as a factor. So I'd say staging for all the young guys out there, prove to yourself that it does create indirect reduction. You will prove to yourself by staging. If you do intervening x-rays, you're going to see how much you got and fine tune what you need without going gestalt with multiple osteotomies. More importantly, you convince yourself you don't need a long construct when you see this. And that's something you have to see to believe. Otherwise, you just keep doing the same thing you did every day. And more importantly, 2 short surgeries of 3 to 4 hours. Don't forget, these are 70, 80-year-old patients instead of 6, 8, and 10 hours. And we haven't had a single patient go to the ICU in years. And I think that makes a very big difference. So today I still will stage. Anything 4 or more levels, I will stage. Young patients, we do the same day. Young, healthy, 40 to 60. And if I can get done within 6 to 8 hours, I'll do it the same day. But any doubt, my threshold for staging is extremely low. So I'd ask you to look at that. I think it'll make a difference, especially when you're starting off. Thank you. There's a fellowship. Anyone wants to do what we have. It's a super fellowship, post-spine fellowship. We take candidates 6 months doing just minimally invasive deformity. And we've had some tremendous success and really enjoyed working with the new fellows. Thank you, guys.
Thanks, Dr. Anand. That was pretty awesome. I have a couple of questions. Those are really cool cases, but in the past, I think some of the attendings have dominated this conversation. So I want to open it up to any fellows maybe who have questions so that they can get their questions in first for Dr. Anand.
Yeah, sure. Dr. Anand, this is Shalan. I'm one of the fellows at Scripps right now. You had mentioned at the beginning of your talk that you do not recommend doing X, and correct me if I'm wrong, that's not what you said.
Sorry, do not recommend doing what? I lost you.
I think you're breaking up, Shalin.
Or have you different that led you to say that?
Did anyone hear that? Do not recommend doing what? I missed that.
Yeah. Say it again, Shalin. You broke up.
All right, well, Shalin's having, I think, some trouble. Any of the other fellows have questions that they want to ask?
Believe it. Or have you had a different experience that you now go anterior?
I'm sorry, you will have to repeat that. I'm so sorry, I didn't get it.
It's okay. If someone else could go, I'm going to try to get some better.
I can hear you now.
We can hear you
now.
Okay. Do you, at the beginning, you mentioned you recommend against going direct lateral X-lift and in specifically for deformity. Does that have to do with particular experience you had with trauma to the psoas, or was there a different reason?
Okay. Yeah. So from 2003 to 2011, I did regular transpsoas laterals. And yes, we unfortunately did have, and I've openly said it, I had 4 full-blown quadriceps palsies. Absolute quadriceps palsy. We're not talking of paresthesia here and there. 0/5 in recovery of the quadriceps. When the 4th one happened on my 213th case on the wife of a very good friend of mine, I was done. Monitoring was perfectly normal. Everything was normal. 20 minutes we were done with each level. And by then I thought I knew how to do a lateral. So if that really shook me, we had to change. And that's when I moved to pre-psoas. And yeah, today I do them all pre-psoas. And I like to look where I'm docking. I see where I'm docking on a direct vision. We do not mobilize any vessels. We find our trajectory purely through anatomy and the MRI and keep it really, to me, MIS is not moving anything. Find anatomical corridors to operate in. There are numerous God-given corridors. You'll be amazed when you study anatomy, how much there is. So yes, that's the answer. That was personal for me. And so I've changed, but I've got nothing against anybody doing anything safe. It just didn't, in my hands, I didn't like it. That's all.
Understood. And one more quick question. Are you getting post-operative CTs or any imaging after your stage 1 to help you plan stage 2? Or is it based off of clinical symptoms only?
No, X-ray. We get a standing full-length Scully film. They're up and walking. Monday, first stage. Wednesday, they get the X-ray. Thursday, we operate. No CT scans or MRIs, unless they got persistent leg pain, or obviously, I'm worried about something being off. So very rare. Answers no. Today, we do robotics with the pre-op CT. So the pre-op CT is still used for the robotic placement of screws now.
Understood. Thank you.
Okay.
Any other fellows with a question?
Yeah, hi, Dr. Anand. This is Cody. I'm one of the Scripps fellows. You mentioned as long as you have an open disc space, you feel like you can get it MIS. Is there anything you see on pre-op imaging that would stop you from trying to correct these things MIS besides the disc space being open, like bridging osteophytes in the back or other things like that you feel like you can get through?
Great question. So a couple of things. Yes, so disc is open. First thing we make sure is that it's not fused, right? There's no posterior fusion on CT scan. So everyone gets an MRI, CT scan, bone density. You need a T-score at least less than -3 and put on teriparatide if they're going to have a fusion. CT scan, make sure it's not segmentally fused. Obviously, you can't do a lateral if the facet's fused. On the MRI, we're looking at the vasculature since I'm going pre-op. all I look at is the bifurcation of the vessels. Embryologically and anatomically, it goes with a high riding psoas, which goes with a high crest. What does that mean? If your vessels have already bifurcated above 4-5 and well bifurcated, that psoas is always high riding, and that crest will be in your way, and that's behaving like a 5-1. So all I care about now is where they bifurcate, and am I going lateral to the aorta as in a true pre-psoas lateral, or am I going in the bifurcation as in an ALIF? Secondly, if it's bifurcated, your vascular surgeon doesn't need to mobilize anything other than take the middle sacral and put retractors in. There's no retraction of the vessels. When you do an ALIF at 4-5, that is not MIS at all. You're totally mobilizing those vessels by taking them. And those are things I think that are important if you're thinking of doing things MIS. So yes, so for us, MRI very important. Determine how you're going to approach it. Are you going lateral to the aorta or going in the bifurcation? And then you have to do an ALIF in the lateral position. And to that effect, you need a good vascular surgeon for the exposure. And I think that's where that issue may come up. If not, do it supine. Do a supine ALIF. It's okay. Hope that answers your question.
I think we have time for one more question. So if I might, Dr. Anand, I think a lot of our fellows will feel pretty comfortable with ALIFs and laterals. But I think what distinguishes sort of your technique and your method is what you do posteriorly for the coronal correction. So can you just briefly talk about sort of what you've learned in terms of translation, rotation, those types of things, and how you achieve that from an MIS approach?
Well, honey, thanks for asking. That has never been talked about. And I think I'm realizing it's a very critical part of what we're doing. So it starts with one, it determines how much lordosis you still need. Like we already showed, most of it's achieved with the first stage. It's that coronal correction. So one of the key things is first, titanium rod. Do not use cobalt chrome. Every single rod of ours is 5.5 titanium. You want to give between the rod and the spine. You're basically reducing the spine to the rod. Reduce the apex of the lordosis first. The rod is kept in strict sagittal alignment. You got to hold the rod. It's bent in sagittal alignment. There's not a single coronal bend. So when you do that and then you reduce it, the spine rolls to the rod. And there's a give between the two. And that give takes some understanding and learning. Or if you force it, you rip the screw out. There's a give between the rod bending and the spine moving. And I look at the lateral as being a release. It sort of releases your spine to give you a little more play there. It's not segmental play. It's global play. I hope this is making sense. The whole spine's rotating. It's not segment. And adults don't need segmental correction. Adults need global correction. And all they care about is their pain is gone. They're so happy once their pain is gone and they're standing straight. That's it. That's all they care about. They don't care about our numbers and the curves. So anyway, so I think that'll make sense, but there's a more to it than that. It's a graduated reduction, distribute the forces, don't use cobalt chrome. And our hardware failure rate is 3%. We're publishing that now soon. So there's a lot more than I think even we know now. Yeah. Hopefully we can study and keep getting it out.
Well, from looking at your x-rays, my guess is that that's where a lot of the magic comes in and sort of that gradual coronal correction without having to do osteotomies. So you might have to come up to Los Angeles to watch how you do it because it sounds like it is pretty nuanced.
Anytime. My pleasure.
Well, we're at the 8 o'clock mark, or 7 o'clock mark rather. So thank you so much, Dr. Anand, for speaking to our fellows and to us. Awesome talk. We're going to post this on the internet with your permission, Dr. Anand, so that fellows who couldn't be here this morning can learn from it. We'll send the next email out for next month's conference pretty soon. But have a great day, everyone, and thank you so much.
Thanks, Neel. Appreciate it.
Appreciate it.
Thank you, guys. Real honor and pleasure. Thank you so much.
Thank you, Neel.
Have a great weekend.